Namaste Betiya, Hamisha Khush Raho Betiya. A very good morning to you all. Myself, JVN Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, in Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, we are discussing about the various hematological diseases. In the last lecture, we were discussing about lymphoma, and we had discussed about Hodgkin's lymphoma. In today's lecture, we are going to continue from the previous lecture, and we are going to discuss about non-Hodgkin's lymphoma. What is non-Hodgkin's lymphoma? What are the etiological features, the clinical features, investigation, and management of non-Hodgkin's lymphoma? This we are going to study today. So let's start with the non-Hodgkin's lymphoma. I will also give you a brief review of the lymphoma, that is Hodgkin's lymphoma, that we have studied in the last lecture, right? So I believe you must all have gone through the Hodgkin's lymphoma from the keynotes and the matter that I have given to you, and also you must have seen from the book. So let's have a quick review. What did we discuss in the last lecture? So in the last lecture, we have discussed about the malignancies of the lymphoid cells. In the malignancies of the lymphoid cells, we have discussed that these are the most indolent, most aggressive type of malignancies that we can see. Lymphomas are arising from the immune system at different levels of differentiation, and a wide range of morphological, immunological, and clinical findings are present. Some of the malignancies of the lymphoid cells are present as leukemia, and the other are present as lymphomas. So in the lymphomas, we have discussed that these are arising from the lymphoid tissue and are characterized by the lymph node enlargement. So in lymphomas, we have lymph node enlargement, there is splenomegaly, and constitutional symptoms. The constitutional symptoms include fever, sweat, anorexia, and weight loss. And this is followed by the fatal outcome. So lymphomas we have classified as Hodgkin's lymphoma and non-Hodgkin's lymphoma. Hodgkin's lymphoma were characterized by the presence of the Reed-Sternberg cells. We had also discussed that Hodgkin's lymphoma has bimodal distribution, and we have also discussed the 4 stages of the Hodgkin's lymphoma. In the clinical features, we have studied about the local signs, the systemic signs, and the clinical features due to the local metastatic growth or infiltrations of Hodgkin's lymphoma. In the investigations, we have covered the lab investigations and various imaging techniques that could be done in case of Hodgkin's lymphoma. And then we have discussed the management, that greater than 90% of the patients of Hodgkin's lymphoma are cured. And so Hodgkin's lymphoma is having a comparatively better prognosis. We have also discussed about the 4 things, or the 4 classical Hodgkin's lymphoma subtypes, that is nodular sclerosing, mixed cellularity, lymphocyte rich, and lymphocyte depletion. So all these things we have discussed in the last lecture. Now today let's start with the non-Hodgkin's lymphoma. Now, what is non-Hodgkin's lymphoma? Non-Hodgkin's lymphoma is basically a heterogeneous group of malignant disorder. So what is present in non-Hodgkin's lymphoma is a heterogeneous group of malignant disorder that are characterized by the replacement of the normal lymphoid structures by diffused and nodular collection of the abnormal lymphocytes. So in the heterogeneous group of malignant disorder, it is characterized by the replacement of the normal lymphoid structure by the diffuse and nodular collection of the abnormal lymphocytes. In the non-Hodgkin's lymphoma, a monoclonal proliferation of the lymphoid cells of the B cells that occurs in 70% cases, and T cells that is occurring in 30% cases. These are of origin. So there is, in the non-Hodgkin's lymphoma, there is a proliferation of the lymphoid cells. Of the B cells, it is seen in 70% of the cases, and the T cells that is seen in the 30% of the cases. Now, how to classify non-Hodgkin's lymphoma? In the classification of the non-Hodgkin's lymphoma, it is divided into the following types. The non-Hodgkin's lymphoma are classified as low or high-grade tumors. So the non-Hodgkin's lymphoma, it can be divided into two types of tumors. One, we have low-grade tumor, and the other is the high-grade tumor on the basis of their proliferation rate. So we have low-grade tumor, we have high-grade tumor on the basis of their proliferation rate. In the low-grade tumors, the low-grade tumors divide slowly. So therefore they are called as the low-grade because they are dividing slowly and may be present for many months before the diagnosis. So low-grade tumors are basically divided. They divide very slowly and before the diagnosis, and they typically behave in the indolent fashion. Therefore, the name is suggesting low grade, but it is not curable by the conventional therapy because this is dividing slowly, and till the time we come to know about this particular tumor, a lot of advancement has already taken place. The second variety is the high-grade tumor. High-grade tumors, in this, the cells divide very rapidly, and they are typically present for a matter of weeks before the diagnosis, and it may be life-threatening or fatal if untreated, but it is potentially curable. Because of the high rate of division, it is easily diagnosed at a very early age, and hence it can be treated properly. But if not treated, then it can become a life-threatening disease. Now, what is the etiology of non-Hodgkin's lymphoma? The exact etiology of non-Hodgkin's lymphoma is basically unknown, but there are a number of environmental factors that have been implicated in the occurrence of non-Hodgkin's lymphoma. So the etiology of non-Hodgkin's lymphoma is unknown, but there are a number of factors that have been implicated in the occurrence of non-Hodgkin's lymphoma. These factors include the infectious agents. There are different types of chemical exposures and medical treatments. So there are a number of environmental factors that have been implicated. These include the infectious agents, the chemical exposures, and the medical treatment. The infections includes, in case of bacteria, it is H. pylori. In case of virus, there is Epstein-Barr virus, HTLV, human T lymphocytic virus. There are various immunodeficiency conditions like immunosuppressive therapy and HIV. There are also different autoimmune diseases, ionizing radiation, and carcinogenic chemicals. So we have immunosuppressive therapy, HIV, we have autoimmune disorders, ionizing radiations, and carcinogenic chemicals. Now, what is the incidence of non-Hodgkin's lymphoma? Non-Hodgkin's lymphoma is more frequently seen in the elderly, and the incidence increases with the age, that is 62.8 million population per annum at the age of 75 years. So the incidence of the non-Hodgkin's lymphoma, it is frequently seen in the elderly population, and the incidence increases with the age, with 62.8 million population per annum at the age of 75 years. It is more frequent in men. So it is more commonly seen in the men, and the patient with both primary and secondary immunodeficiency state are predisposed for development of non-Hodgkin's lymphoma. The incidence, it is more common in the elderly, and the incidence increases with the age, and there is 62.8 million population per annum at the age of 75 years. It is more frequently seen in the men. The patient with both primary and secondary immunodeficiency state are predisposed for development of non-Hodgkin's lymphoma. Next, we come to the clinical features of the non-Hodgkin's lymphoma. In the clinical features, you will observe painless lymphadenopathy. So whenever a patient is coming to us for non-Hodgkin's lymphoma, we are going to see or observe painless lymphadenopathy. And this lymphadenopathy is usually widespread. It is not localized or contiguous, but it is widespread lymphadenopathy. The constitutional symptoms will be present. The constitutional symptoms, as we have told in the Hodgkin's lymphoma, they consist of the fever. There is fever, sweat, anorexia, and weight loss. So there is painless lymphadenopathy. There are constitutional symptoms, which includes the fever, sweat, anorexia, and weight loss. There are respiratory symptoms, which includes the pleural effusion, mediastinal lymph node enlargement. There is parenchymal lung involvement. So it can be painless lymphadenopathy that is often widespread and more contagious, contiguous. Constitutional symptoms, which includes the fever, sweat, anorexia, and weight loss. There are respiratory symptoms, which includes the pleural effusion, mediastinal lymph node enlargement, and parenchymal lung involvement. Now, there is also involvement of the different sites which include skin mycosis fungoides, tonsils, adenoids, salivary gland, GI tract, and the testes. So these can be involved: skin mycosis fungoides, tonsillitis, adenoids, salivary gland, GI tract, and testes. There can also be extranodal involvement that is common in the T cell disease, and it involves the bone marrow. But the thyroid, lung, skin, testes, brain are more rarely seen. So the extranodal involvement is more common in the T cell disease, and it involves the bone marrow, gut, thyroid, lung, skin, testes, brain, and more rarely bone. There can be hepatosplenomegaly that can be present. So in the clinical features, we are going to see painless lymphadenopathy. There will be constitutional symptoms of fever, sweat, anorexia, weight loss. There will be different type of respiratory symptoms, which includes pleural effusion, mediastinal lymph node enlargement, parenchymal lung involvement. There will also be involvement of the other sites, which includes skin mycosis, fungoides, tonsils, and adenoids. There will be salivary gland involvement that includes the GI tract, testis, etc. In the extranodal involvement, it will be more commonly seen in the T cells, and it involves the bone marrow, gut, thyroid, lung disease, testis, brain, and more rarely bone. There can be hepatosplenomegaly. Now, what are the investigations that could be done in case of non-Hodgkin's lymphoma? For diagnosis of the non-Hodgkin's lymphoma, we have to do the routine bone marrow aspiration and trephine. So the bone marrow aspirate can be taken down, and trephine, immunophenotyping of the surface antigen to distinguish B and C cells tumor. So we can do the routine bone marrow examination. We have to check for the immunophenotyping of the surface antigens to distinguish the T and B cells tumor. We can see for the immunoglobulin determination. So there can be immunoglobulin determination of the some lymphomas that are associated with IgG and IgM. So we have immunoglobulin determination. We have done routine bone marrow aspiration. There is immunophenotyping of the surface antigen. There is immunoglobulin determination that is associated with IgG, IgM, paraproteins, which serve as markers for the treatment response. There is also measurement of the uric acid level, that is very aggressively high-grade non-Hodgkin's lymphoma are associated with high urate levels. So you have to check for the uric acid level. More the uric acid, more is the high-grade or aggressive non-Hodgkin's lymphoma. We have to check for the HIV for identification of the immunocompromised states. In the hematological examination, we are going to observe normocytic, normochromic anemia, leukoerythroblastic anemia that can be seen in bone marrow infiltration. There will also be hypersplenism because of excessive destruction of the RBCs. There can be neutropenia and thrombocytopenia, that is a reduction in the number of neutrophils and the platelet count. Because of the inflammatory conditions, the ESR and the C-reactive protein will be raised. So in the investigation, we have done the bone marrow aspiration, immunophenotyping, immunoglobulin determination by the presence of IgG and IgM paraproteins, measurement of the uric acid level, HIV testing, hematology, leukoerythroblastic anemia, hypersplenism, neutropenia and thrombocytopenia, and raised ESR and C-reactive protein. Now, how to manage the case of non-Hodgkin's lymphoma? Now, for the management of non-Hodgkin's lymphoma, there are two varieties of treatment, as we have discussed about two types of non-Hodgkin's lymphoma. One is low grade and one is the high grade. So we have a separate treatment for both of them. In the low grade lymphoma, we have to wait and watch. There is asymptomatic patients which do not require any therapy. Indication for the treatment includes marked systemic response, lymphadenopathy causing discomfort or disfigurement, bone marrow failure, or compressive syndromes. We can go for either chemotherapy, we can go for radiotherapy, or the monoclonal antibody therapy. So when do we use radiotherapy? Radiotherapy can be used in case of localized stage disease that is rare. Chemotherapy, it is most of the patient will respond to the oral therapy with the chlorambucil. Monoclonal antibody therapy, that is humanized monoclonal antibody target surface antigens or the tumor cells and induce tumor cell apoptosis. So these monoclonal antibody will lead to the death of the tumor cells. Rituximab is a combination of cyclophosphamide, vincristine, and prednisolone that is recommended as a first-line therapy. Bone marrow transplantation can be done with a high-grade dose of chemotherapy and bone marrow transplantation in the patient with relapse of the disease. So we can give our CVP therapy. Bone marrow transplantation can be done with the high dose chemotherapy and bone marrow transplantation in the patient that are getting relapse of the disease. Next, we come to the high-grade non-Hodgkin's lymphoma treatment. For the high-grade non-Hodgkin's lymphoma, it requires a treatment at the initial presentation. So whenever a patient is coming to us, in the initial presentation, we have to go for the treatment. The treatment includes, again, the same as that of the low grade, that includes chemotherapy, radiotherapy, monoclonal antibody, and the bone marrow transplantation. In chemotherapy, the majority, greater than 90% of the patient are treated with the CHOP regime. The CHOP regime we have discussed in the Hodgkin's lymphoma. That includes cyclophosphamide, doxorubicin, vincristine, and prednisolone. The radiotherapy, it is indicated for the residual localized site of bulk disease after the chemotherapy and for the spinal cord and other compression syndromes. The monoclonal antibody therapy, when it is combined with the CHOP chemotherapy, rituximab, it increases the complete response rate and improves the overall survival. So monoclonal antibody therapy increases the survival in case of non-Hodgkin's lymphoma. And in both low-grade and high-grade disease, bone marrow transplantation, autologous bone marrow transplantation can be done. Now, what is the prognosis of non-Hodgkin's lymphoma? In the prognosis, the low-grade non-Hodgkin's lymphoma runs an indolent, remitting, and relapsing course. So there is indolent, remitting, and relapsing course in case of low-grade non-Hodgkin's lymphoma, with the overall median survival rate of 10 years. There is transformation of the high-grade NHL that is associated with poor survival. So if low-grade is transforming into high-grade, then there will be poor survival rate. In the high-grade non-Hodgkin's lymphoma, around 80% of the patient overall respond initially to the therapy, but 35% will have disease-free survival of around 5 years. So this is all about the non-Hodgkin's lymphoma. There is also an international prognostic index for non-Hodgkin's lymphoma that I have discussed with you in the e-notes. So I would like you to go through the e-notes and check for the international prognostic index for non-Hodgkin's lymphoma, because it is not asked in the examination. Therefore, I am not discussing this particular topic in this lecture. So this is all about lymphoma. We have discussed about definition of lymphoma, Hodgkin's lymphoma, non-Hodgkin's lymphoma. Now, I would suggest you to go through the e-notes that I have uploaded. You have to answer the questions that I have given to you. And you should also see for the, refer the book for the following topics. So this was all about lymphoma. In the next lecture, we are going to discuss about megaloblastic anemia. So this session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you have understood this session properly. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.